For this lecture, we will discuss Chapter 13, Donor Selection and Phlebotomy. So your blood centers or your transfusion services are the ones that are going to provide and are responsible for providing an adequate blood supply for the patients that you serve. So within that measure, blood centers have to go through strict criteria that are established by the FDA as far as what is acceptable for a blood donor. And so what they do is provide guidance, documentations, and different things to the blood industry in order to help facilitate these regulations. Now the AABB, that's a voluntary accreditation agency, but they also establish guidelines for the blood donations, and they have written the standards for blood banks and transfusion services. And so what they actually do is help to establish the donor history questionnaires which will actually provide some uniformity and clarity for determining if a donor is eligible to be a volunteer donor. And within that documentation, all of this must meet the FDA requirements for screening those donors in order to determine if they are an acceptable donor based off of the criteria that sets those safety guidelines. So once a volunteer donor decides that they want to donate blood, there is a process that is followed in order to ensure that that product is the safest possible product that can be provided. Now in that process, you're going to have a step of registration. So this is when the information about the donor is verified and all documentation is performed. And so whoever is registering the donor will get information like the donor's full name, their permanent address and contact information, date of birth, their gender, and the date of their last donation. And so they will compile all of this data as well as provide the donor with educational materials. And you can see an example of the education materials that is provided to the donor here in this image. And so this is provided to the donor, and the donor can review over these as well as various instructions for after donations. They are provided that as well. But just to kind of give them an idea of their eligibility. And they are also, during this whole registration process, the donors are also interviewed, and they have a health questionnaire that they will complete as part of that interview process. So within that interview process, the questions are really geared for two purposes: to basically protect the donor in situations that could cause issues for the donor themselves, as well as to protect the recipient. So just to make sure that the product is the safest product that we can possibly provide to the recipient. So depending on the results of the medical history or prior tests that have been done, a donor could potentially be deferred in some way, or they could proceed on through the donation. But as far as deferrals, they can be divided up to indefinitely or a permanent deferral, as well as temporary deferrals. So things that can cause an indefinite or as well as a permanent deferral, these are going to include things like a history of viral hepatitis after the 11th birthday, or things like confirmed positive hepatitis B surface antigens and antibodies to hepatitis B core, as well as several of these other things that are listed here. So if a donor states that they've ever been diagnosed with one of these or have a risk of being diagnosed with one of these, then they would be deferred. There also are deferral procedures based on the possibility or the potential for a transfusion transmitted type of infection. So if the health questionnaire kind of indicates that there's some kind of infectious disease or malaria, possible tick-borne type of infections, or things like Chagas disease, or Creutzfeldt-Jakob disease, so that could be an exposure from over in the United Kingdom. So if there's a possibility of these, if a donor meets this criteria, then they could potentially have a intermittent type of deferral or a short deferral, a year, 2 years, 3 years, depending on what it is, as well as even an indefinite deferral. There may also be medication deferrals. Now, medication deferrals aren't really necessarily based off of the medication itself, but more or less the potential disease or the disease process that actually requires the use of that medication. Things like antibiotics, anticonvalescents, anticoagulants, insulin, antiarrhythmic type of drugs like cardiac type of drugs can cause temporary deferrals, but there are some medications that are listed that do cause that are considered acceptable as far as the type of deferral. So anytime a donor goes in and they're going through that interview process, they will list the type of medications and things that they use, prescription as well as non-prescription types of things, including vitamins and stuff like that. And of course, you do have the medication deferrals just from some specific medications that are listed here that can cause shortened type of deferrals. For example, someone that's on aspirin, which is that non-steroidal anti-inflammatory drug, that particular deferral is 2 days after the last dose if you have someone donating and you plan to make platelets out of that. So that is just simply because of the action that aspirin has on platelets. And so essentially, if a donor has been using an aspirin product, and then that donor, you use that product to make the platelets out of, then those platelets would actually lose a little bit of their ability to actually form that clots because of aspirin's effect on platelets. There are several things that can cause temporary type of deferrals. For example, vaccines. Donors receiving vaccinations that are prepared from toxoids or killed organisms do not require any sort of deferral if that donor is symptom-free, except if there's situations where the donor received like an intranasal live attenuated flu vaccine or any sort of other attenuated vaccine or bacterial vaccine. They will require a temporary deferral, and you can see some of those listed here with that 2-week deferral or 4-week deferral. If the donor has high risk type of activities, that could cause a deferral. Pregnancy can cause a deferral. A lot of there are various reasons why you would defer someone after pregnancy, just because pregnancy tends to lead to a little bit more of a blood loss for that female patient, as well as that mom has that potential to have made antibodies from that pregnancy. So just given time for those antibodies to kind of produce and be present if they're going to be. So several different reasons why you would do a deferral for after pregnancy, to include protecting the mother as well as protecting the recipient. So the physical examination is also part of that whole process of interviewing the donor. And so with the physical examination, the donor should just appear to be in a general good health type of state. If the donor's a little weaker that day or just looks like they're not feeling well or anything like that, then that could be a flag that something's starting, so you wouldn't want to do that donation, as well as that could put further injury on the donor themselves. If they're a little weaker that day or dehydrated, things like that, then it can cause issues for that donor when they get that sudden blood volume loss. But other things that need to be noted is that donors are not acceptable if they are suspected of having an alcohol or drug abuse problem. And so they would potentially be deferred. And some of the other things that where the criteria must be met would be to make sure that the donor is of an acceptable age. They must you must adhere to the state laws, or they must be over 16 years of age. They must meet minimum weight requirements, as well as other things like their temperature, blood pressure, hemoglobin, hematocrit, so they'll check that with a finger stick. Pulse, they'll do blood pressure, things like that, just to make sure that the donors overall seems to be in a good general state of health. And I also just want to make mention that that 110-pound weight limit, some donors can be allowed to donate at about 100 pounds or even less, as long as the donor meets certain criteria. Then what they can actually do is just draw a lesser blood volume off of that donor to do like a smaller unit that could still be therapeutic for someone. It's just, it would allow that donor to give a less volume and it not be quite as traumatic to their system. Now, the phlebotomy process includes making sure that you properly identify and confirm the patient's identity, making sure that the bags and things are properly labeled with the registration information. Now, donors are voluntary and they are they're kept anonymous, so it's usually a unique number that is associated with that bag that's going to include an ISBT type of labeling. And of course, the important part, one of the more important parts, which every step is pretty important, you know, making sure that you keep your process sterile, but as well as making sure the identity is correct, because you need to be able to trace that unit of blood back should an issue arise, and making sure that it's properly labeled. So these are all important parts, but making sure that you prep the donor properly, making sure the arm is prepped properly, and that you perform the venal puncture properly is also important, because we need to make sure that we maintain that closed system environment, that we're not introducing bacteria, because these products will be stored, so you don't want to actually be growing bacteria, some kind of organism in that blood bag that would lead to an infection or harm the actual recipient, because more than likely they're already having issues. So preparing the arm, you would actually draw from the intercubital area of when you're doing the stick. And also you want to make sure that the site is cleaned with a 7% aqueous iodophor solution, and that's going to be followed by a povidone iodine solution that will be used to clean the arm. So you're doing multiple steps of that cleaning process, and of course there's a particular pattern of cleaning it from the inside out, just like you would do with blood culture collections, just to ensure that that site that you're actually going to stick is a clean site. Now, the needle gauge is a 16 gauge, so it's a pretty large needle that is used. As far as a typical donation, so most of your just straight needles are going to be this green needle. That's a 21 gauge needle. So you can see the size of the 21 gauge needle here of your typical blood draws that you will perform for just blood testing, depending on, you know, what the particular stick is. If you're going to do like a butterfly stick, those gauges are usually about 23. That lighter blue color would be like a butterfly stick. So your donor needle is that 16 gauge needle. So it's a really big needle compared to that typical 21 or 23 gauge needle. So once it's decided that a unit will be collected from a donor, now just keep in mind that even though the unit's collected, that does not mean that it's going to be used. It's still, those questionnaires have to be verified and reviewed, making sure, you know, every question was answered and things like that. There's some checks and balances that happen within a donor center. And if there's any questions or anything needs to be approved, then it will have like a pathologist or physician review those documents to determine if that donor is eligible, and of course the testing has to be done as well before that unit is put into use. But the collection process is basically using a tourniquet or a blood pressure cuff, identifying that collection site, cleaning that collection area, performing that stick, and then covering that area with a sterile piece of gauze while that phlebotomy process is taking place. And so covering that area with the gauze while the needle is still in the arm is just basically to prevent any other contamination to that area while that unit is being collected. Now, the unit bag itself looks a little different, and I'm going to try to explain it to you. And there are different collection sets and things like that. But this particular set, so you have the needle area, I think that's the needle area, and then the bag will kind of divide off into two directions, so you can see where it kind of divides here. And so this one direction, you can kind of see where you have a little valve here that you can kind of clamp it off, as well as here kind of controls the flow as well. But what you see here is a little pouch that is used to actually do the sampling for testing, because we want to test what's actually going into the bag. And once it goes into the bag, we can't enter that bag because we could potentially contaminate it with some sort of bacteria or organism. So in order to prevent that, you have this little satellite bag that is allows the blood to flow in this bag, and then once that's filled up, they'll seal that off, and then they'll allow the blood to flow through this process, and then it'll go into the overall larger collection bag. I think it will probably be on this end of it, one end or the other, not really sure which, just because all this is kind of laid over each other and it's kind of hard to see. But during that process, you can see this actual donor was collected. You got the little bit that goes into the satellite bag, and then you got, once that's clamped off, the rest will go over into the donor bag. And then from this bag, once they've performed that collection, they will actually have a set of test tubes that they will use, and they will pull off of this little satellite bag to collect that blood so that they're not contaminating this system. And then that's what will actually have the donor testing performed on that unit. And so all of those tubes are labeled, and they're kept with the actual bag, usually rubber banded to it or somehow with that bag, and it follows it through its process until those tubes are sent out for testing or wherever they go for testing. Now, what you see here is a little device. So once this kind of comes out of the patient, you can see the bag is here, but it's usually laid on some kind of tray, or it's weighed in some kind of way where once it reaches a certain volume, then you have this little device right here that will actually clamp that and seal it off so that you're not taking too much out of that donor. So once it reaches that weight volume in this little tray, and of course this little tray will actually rock while it's being collected, so you'll just kind of see it shift from one side to the other, just to keep that blood mixed with the anticoagulant that is inside of these bags. So it's hard to see here, but there's usually something in there, a preservative, anticoagulant, that will help those units to survive while they're in storage and prevent it from clotting up and things like that. Now keep in mind that anytime you have a donor go through this process, it can be a little traumatic to the system, losing that blood volume pretty rapidly. So while a donor is donating, they are trying to constantly do things to kind of keep that donor a little stable, you know, giving them juice afterwards, having them sit for a little while to rest, making sure they feel okay, and checking them after that donation, just looking for any kind of symptoms. But some of the things that you can see will be, of course, the donor potentially passing out, getting weak, nauseated, vomiting, things like that. They could get a hematoma from the site. There can be some muscle twitching and things like that, spasms, cramps, and other cardiac difficulties. So basically you're going to observe that donor for those symptoms, and then if they are, you're going to try to treat them. If anything is beyond the measure of what the donor center can handle, of course they'll seek emergency medical attention for that donor. And of course, donors are provided with a set of instructions on their care after their donation. Again, since you're losing that blood volume, some people actually feel better after it. Some people get a little weaker. Everyone's a little different, but you know, it's really important to just make sure you're maintaining that hydration and drinking a lot of fluids to keep that volume within the body up. Being aware of your body, laying down if you feel dizzy, fainting, things like that. And as well as, you know, the donor should, if the symptoms persist, notify the donor center just to kind of get advice if additional medical treatment is required. So there are a few types of donations. We have allogenic donation. So this just kind of goes to the general public population. You have autologous donations in which someone donates to themselves. And there's also another one that I'm going to mention, which is directed donations, and we'll talk about that shortly. But with autologous donations, there are advantages and disadvantages to doing an autologous donation. Of course, you know, you're getting your own blood back, but in that same sense, you're also decreasing your own volume. So, you know, if you may be doing a procedure that may not be necessary. Sometimes people just like to do autologous donations because they just kind of have a fear about receiving blood. So they could potentially do donations in advance of a surgery or anything like that, just to have that blood available to them should they need it. But some of the studies over the years have found that by lowering that patient's blood volume going into surgery, it actually causes more harm than if you would just let them go through that natural process of bleeding and clotting off during a procedure or anything like that. But we are going to talk a little bit more about some of the various autologous donations. So you have that preoperative donation where the donor can actually go in and donate blood to themselves leading up to a surgery or procedure or something like that. And they must meet certain criteria in order to do that. And then that blood would be specially labeled for the intended recipient, which would be the individual that donates doing that autologous donation. The next form of autologous donation would be a normal volemic hemodilation. And so what this process does is once the patient is actually started on anesthesia and put under, the anesthesiologist will remove a specified volume of blood that's determined ahead of time. So they'll go ahead and take that out, and then what they'll do is actually replace that volume back with fluids. And then that way during the surgery, so if it's a surgery that's a little bit more of a risk of bleeding, then the blood that's actually lost during that bleeding process, it's a diluted version because you have the fluid volume that's been replacing the actual blood volume that was withdrawn. So that fluid that is diluting out the blood within the system is actually what's being bled out. And so once they get the patient stabilized, they can start returning the patient's own blood to them, and that just results in the patient getting their own blood back and losing less of their own cells, and hopefully potentially not requiring an allogenic type of donation from a random donor. And then your blood recovery is basically a medical device that's used during surgery to collect the blood that is lost during that process. And what it will actually do is go through a process of washing those cells, filtering it out, and then concentrating those blood cells down and giving those back to the patient during that surgery process. Now, with this particular process, you know, you do have the risk of bacteria being exposed to that blood. So if you're doing any kind of surgery that's actual, you know, you run the risk of their contamination being there. So for example, you know, fluid in the abdominal area from, let's just say, some type of like appendix ruptured or anything like that. That's going to contaminate that fluid. So that's not something that would probably be used, but you know, there are other ways to kind of prevent or give that patient that blood volume back and not introduce bacteria. So there's other alternatives, so it's probably not as widely used. Now with that preoperative donation, they don't do that high-risk questionnaire as far as, you know, their exposure to potential infectious diseases because they're getting their own blood. So it doesn't, you know, if they already have a disease process or you know, any sort of infection or anything like that, then they're getting their own blood back. There's no age restrictions, and again, if their weight is less than 110 pounds, of course there would be a volume adjusted, and they have to have a hemoglobin above 11 or a hematocrit above 33, and they cannot donate up to 72 hours prior to surgery. So whatever they would need to do, if they wanted to do those donations, they would have to have the timing just correct to get enough units donated prior to that 72-hour period prior to surgery. And of course, here you can see the process of that intraoperative cell recovery. You can see where they're removing that blood, and it's going to go through that process of filtration, and then this is probably the wash solutions and things like that, and then it's going to go back into the patient themselves. This just kind of gives you an overview of it, where you have different lines that are going in. You've got the blood cells, and then you have the waste buckets as well. So it's just kind of all built within the machine, but you can kind of see the various processes that take place during surgery. Okay, there's directed donations. Now these are donations that are directed to a specific recipient. Now there's not really been any evidence to support the theory that directed donations are safer than allogenic donations, but some people just would rather receive it from a family member, but sometimes you run into some sticky situations there because they do have to meet the same criteria. So it's very possible that, you know, you could request a family member to do a donation for you, and then they don't meet that criteria and they're deferred for some sort of reason, and then you're not understanding. It kind of gets a sticky situation there. But there is a 56-day interval that may be waived with a medical director's approval as far as those donations, directed donations. So a lot of times when directed donations are used, this is going to be someone that has one of those more complex antibody, got some of those multiple antibodies, and they're a little bit harder to find a specific match of those units, or you may have a rare antibody. So looking for the family member that's related that kind of matches that antigen profile. So if you find a family member, then maybe the family member is going to do that directed donation. So depending on the recipient's needs would depend on how often that donor is allowed. But usually these are going to be the situations in where you use directed donors. So apheresis is a pretty cool process. What it does is allow you to actually just remove from the donor just the product that you want, and then the rest of the part of the product, the red cells or whatever, would go back into the donor. And so you still have to go through the same process of the questionnaires and the donor, checking the donor history and making sure the donor is well and things like that. But once you've gone through that process and you're at the point of the donor being collected, then the blood will actually, you can see the little tube in here where it runs into the machine. And then once it's inside of that machine, it's got this process where it will actually kind of centrifuge it. So you can see this weird little component here, but it kind of centrifuges it, mixes it with some saline type stuff. A few other things in there. It's a little bit more complicated, but once it does that separation product, whatever that you're trying to get from that patient, whether it's leukocytes or platelets, not really sure what this is. It's either plasma or platelets. The bag kind of looks more like plasma. And so it goes into whatever product you're removing will actually go into the bag, and the rest of it will actually go back into the donor. I think this may be the line here that's returning back to the donor. It's really hard to tell because of the color, and it could just be, could be a cord. But the blood cells and a little bit of saline, some other additives that kept that blood from clotting goes back into the patient. For platelet pheresis, donations are made at least 48 hours apart, no more than twice a week, or 24 times a year, and the platelet count must stay above 150,000 in order for them to be eligible to do platelet pheresis. And this is just a better view of one of those apheresis, the pheresis type of machines. So you can also have plasma pheresis, so you're just going to pull off the plasma and then return the red cells, platelets, white blood cells. Plasma pheresis is no more than once every 4 weeks, and then Immunoglobulin G and M, so your IgG and IgM levels, are monitored every 4 months if donations are made more than once every 4 weeks. So if you have a donor that for whatever reason they're requiring that plasma for whatever, if they're using it for any sort of like medication type purposes or anything, then they would need to be monitored. And then red cell pheresis, what this actually does is allows you to draw 2 units of red blood cells off of one donor, and they have to meet certain weight and height criteria. So usually your men that are built a little bit larger and women, they're going to be the ones that are eligible to do this type of donation. And then the deferral for them is actually 16 weeks following that donation of that double red cell unit. But it's really cool when you have a donor that has some of that rare antigen profiles when you get them because that allows you to be able to have 2 units to transfuse your patient. And another thing that it's good for is if you have a patient that's prone to multiple antibodies, you know, giving them the same donor is going to provide them with more of that blood volume from that single donor. And it just reduces the risk of them being exposed to more donors, especially when they're getting frequent donations. And another thing I want to mention that your donor centers will usually will do, if you're a hospital that doesn't have a donor center, they may still have a way to do this. But your donor centers are usually going to do the therapeutic phlebotomies because they can draw off a larger volume at one time. And so what they do is actually take that large volume off of that patient. So it'd be kind of like doing a donor, just a donation. They would do a specific volume based off of whatever the physician orders. And so what it does, it doesn't actually cure the disease process that's causing it, but it does help act as a treatment. So if you have a patient with something like polycythemia or hemochromatosis, or porphyria, then what the patient actually does is they end up having more of that red blood cell production. And so once you start getting a lot of red cells and that hemoglobin starts getting up really high, it's like the blood gets a little bit thicker because you have all of these red cells in there. You have this excess hemoglobin content. So what the patient can actually experience symptoms from that. So reducing that blood volume actually makes them feel better. You'll see a lot of, you'll sometimes see patients that are smokers, they're heavy smokers, that will get that higher hemoglobin, and part of that is just that process of smoking kind of tricks the body into thinking it's not getting enough oxygen because you're getting that smoke inhalation rather than that pure oxygen. Well, not that oxygen's really pure in the air, but you're getting that lower oxygen level, so it kind of tricks the body into thinking that it needs more oxygen, so therefore it kind of starts making more red cells, and then you start getting that higher hemoglobin. So it's pretty cool that sometimes when you're working in the lab, you can tell patients that are smokers or potentially have something like polycythemia, because you can see when you spin that tube down, that packed red cell is going to be a lot more as compared to, I'll give you an example here, compared to someone that's hemoglobin is more within the normal range. So again, you'll spin those tubes down, and then when you spin them down, you'll have your red cells, of course, at the bottom, and then you will have your plasma at the top. So the way it will actually look is you'll have a tube with the same volume, but the only difference is one has more red cells than the other, and so that's kind of an early indicator of what that patient's going to look like. And actually, when you're working in blood bank and your eye starts training to looking at and inspecting those tubes, you're going to notice a difference when you see patients come in that have lower hemoglobins. If you've got about a 50-50 ratio, a little bit less, let's see, kind of bring this up a little bit more. When you're kind of about 50-50 as far as your volume of red cells to your plasma, a little less on your red cells, then your hemoglobin's about normal. But when you start getting just a little bit of red cells in a tube, when you spin it down, and then you have a whole lot of volume of plasma, then that's a very good indicator that that patient's hemoglobin is really low. And another thing I like to look for is if I see that plasma is really faded compared to what I'm normally seeing, so it's almost clear with just a yellow tinge to it, then that would kind of lead me to believe that there's possible contamination and kind of start throwing up some flags that I might need to investigate if there is some contamination, IV type of contamination going on. All right, I think that concludes this lecture.